thank you, all of you, for sharing your knowledge with us. If I understood Dr. Iskandar, he said hydrocephalus has different etiologies and that shunts should be avoided at all costs. And so what I want to know is that shunts, regardless of the etiology, or shunts related to Chiari?
Right. So the first thing you need to understand, if you look at someone like Jerry Grant, for example, or me, we have PTSD from shunts. How many shunts have you revised, Jerry, in your career? Thousands. Yeah. And they are, and it's not a matter of doing the surgery, we like to operate. It's just that every time it's a toll on the family. So when endoscopy came about 30 years ago, that was a huge reprieve for a huge section. So if you very simplistically look at hydrocephalus as either communicating or obstructive, the obstructive hydrocephalus will respond to ETV, the communicating hydrocephalus will not. So if an ETV fails, then you have to shunt. You can't not treat the patient. But we try as best as we can not to, if we can. If there is any possibility that we can do a procedure to avoid the shunt, we do it.
I think would most doctors agree that the shunt should be avoided at all costs, and that the shunt has seemed to be quite a high failure rate?
So yes, most doctors agree, but they also agree that we need to do what's right by the patient, and sometimes shunting the patient is the right thing to do. And you have to differentiate between adult hydrocephalus and pediatric hydrocephalus. Adult hydrocephalus is a completely different, really, beast. The shunts don't fail as much. They tend to develop subdurals maybe when they overdrain. So it's a different, maybe, as you want to talk about?
Yeah, no, I think, and I completely agree with that. But first of all, it's a great talk. And I think it gets back to what you've heard from all of the faculty. You can't just say, I think everybody up here would agree, but let's go a step further. You should avoid surgery at all costs, right? I mean, surgery, I think you saw in several of the talks, is a last resort. You never want to put a foreign body in a patient, especially something that's mechanical and, the shunt's plumbing. But what's really important differentiating, and Ben, I think you just said it, the pediatric population and the adult population are very different. And those numbers are real across the board. And I think it's pretty sobering that since the origination of the shunt to now, the obstruction, complication, infection, it's debilitating not only to these children, but to their parents, to their families. So I don't think there's any hyperbole there that you want to avoid shunts at all costs. But again, I think the take-home message is, what is the cause? Again, chicken and egg. What's causing this? I think everybody would agree. If we could deal with just doing an ETV or doing the Chiari decompression with no shunt, I'm in full agreement. I'd rather do that. The problem is, you have to understand if the cause is underlying hydrocephalus, you're not going to get away with just a Chiari decompression, and you're going to get CSF leaks. And I'm speaking for the adult population. It's been a long time since I did the peds, but I remembered enough where I have PTSD from that.
I'm coming at this from a different point of view, actually. And I agree, you're going to try to avoid surgery at all costs. But let's say you have to have surgery, and we heard some presentations indicating that some of this is caused by auto accidents, whiplash, etc. So my point is, it seems that with a high failure rate, and you have to put a shunt in, when you try to get your case settled or present it to a jury, you got to make sure that they know of this high failure rate, and it may have to be redone. So you got to get more money to take care of that second surgery or third surgery. Would you agree with that?
The question that he had asked earlier it seems simple, but it's actually extraordinarily complex, about a patient that's losing vision, that has a Chiari, and ventricles are getting bigger. And so you're thinking, well, increased pressure is creating the problem with the vision. And so the reason all of us had some trepidation in the way we answered that is because we're worried about vision. We don't want to delay and do something and lose vision, even though we may be doing the right thing. So I was actually thinking potentially erring on the side of something I wouldn't prefer doing, but trying to avoid having somebody get hurt, even though we may be pursuing the correct decision. We know if we decrease the pressure, we'll take care of the vision. But in doing so and putting a shunt in somebody, you change their life. It's a permanent thing. It changes their life permanently. Every time that person comes into a hospital, a cold, a near drowning incident, a car wreck, falling off a building, headaches, we get called for the shunt. Fevers, anything, we get called for the shunt. So it becomes something that is just a box that's checked off for this poor family, that this changes everything, because you're always worried about an obstruction. When I was at Children's LA, there were days where we would operate on 6 shunts, and the first and the 6th were the same shunt.
Again, that's pediatrics. That 50% complication rate is not the same for adults. Adults handle shunts much, much better. And the long-term complications are much lower. And remember my statement that, with an asterisk, patients don't die from Chiari. Patients and kids die from hydrocephalus. They herniate.
Yep.
Did that answer?
Well, the second part of my response was, because there's a high failure rate, we tried selling a case, a personal injury case where someone's got hydrocephalus from a car accident. That you got to get enough for the second or third surgery because of failure rate.
I mean, the question legally is whether someone has acted below the standard of care, right?
No, got nothing to do with that. Just you get hurt, you get in a car accident,
Right.
and one of your claims is that I got this problem, whether it's whether the hydrocephalus, you got these headaches now, and you got a shunt put in to help take care of it. But the failure rate on a shunt is pretty high, so that's not going to, your case is not your damages are not resolved. The issues are not resolved.
I think for that question, we'll sidebar that one. We're all happy to talk to you after about it, because that's a very specific thing, bringing up legal. So let's we'll bring it back to general, and then we're happy to talk to you after, because I think that's a little bit more detailed.
I mean, you've reminded all of us why we didn't become lawyers.
Yeah, exactly right. You want to see a neurosurgeon shut down, just say lawyer.
Am I next? Hello, I'm back here. Okay, so my question is, I was diagnosed when I was 7 with Syringomyelia, T1 to T12, and at the time I didn't have a Chiari malformation or anything else like that, so they kind of told me it was completely idiosyncratic, but as I've done more research, I've realized that is really rare, and there's usually something else going on, whether it's like tethered cord or Chiari malformation. And I've been asymptomatic until this past year. I'm 27 now, so for the past 20 years, I've been asymptomatic. How common is it to be idiosyncratic and just only have that kind of spinal syringomyelia, or would you advise someone like me to do further testing or look more into tether cord, or maybe get rescanned for Chiari? Is it something that could develop later in life, even though it showed I didn't have it when I was 7? I left them speechless.
Before I pass
Yes,
it
you
to
need your imaging.
I'll pass to the world's expert next to me here. But I think you did the right things. You want to rule out other causes, like you did, when you were younger, the Chiari, the tethered cord, or adhesions, anything like that?
I'm not sure if they ruled out tether cord at that age.
Well, that's important. And then, we do in the pediatric practice, we see so many kids with these idiopathic syrinxes that are picked up incidentally. Often they're not symptomatic, which makes us always pause to treat any of these, because a lot of these kids are with these films that show a very prominent syrinx, but they're absolutely normal. And we follow them very rigorously, because I'm always worried with growth that they might change or they might get symptoms, but they don't. But your question about can you develop a Chiari later, or I haven't seen that as much from an idiopathic syrinx, but I'm curious what our birthday master feels.
Well,
Like, can you pick it up later? Can you acquire?
I have not seen somebody with a idiopathic syrinx develop a Chiari abnormality in later life, but I would say that, to quote one of my mentors, it is difficult to make an asymptomatic patient better with an operation. I think if you're asymptomatic, and I've seen a number of patients, my recommendation is to follow them with an MR scan, depending on their age and other circumstances, in a year, in 2 years, so you have more than one point to follow, and just observe with the MR scan and neurological examination, with the understanding that if any neurological symptoms were to develop or anything changes, come back and see me.
One second part of that question is, are there any implications to pregnancy with Syringomyelia? Have you seen throughout the years is it something that could progress symptoms or kind of inflame symptoms in that way? Or just what do you guys advise in that realm?
Do I understand your question? Is there any risk with pregnancy?
Pregnancy, yeah.
Not that I'm aware of.
Are epidurals something that people with Syringomyelia can receive?
Epidurals, I just would say that go to somebody who has really got a lot of experience with epidurals, so that there's no inadvertent puncture of the dura, and it is truly an epidural.
Thank you.
I've got a question, not really a question, a comment. On one side, I hear you don't die from Chiari. And on the other side, I hear if you cough or sneeze, you have symptom increase. So, your brain is significant. It's important. And if something as simple as Valsalva maneuver causes that kind of a problem, how is it that you don't die from Chiari if something significant happens with the pressure?
Because what the Valsalva maneuver, the classic Chiari headache, there's large venous sinuses in the back of the head that are quite large, and it's where the blood gets engorged. And when we cough, we laugh, we sneeze, and the intracranial pressure, there's a buildup of that pressure, but it's temporary. And it's if you kind of map it out, it's not this, it's this, but it's enough where it's going to cause severe headache. Now, again, there's I think you're referring to my comment on that. There's an asterisk on that. There are some severe, especially in the pediatric populations, of some really severe Chiari malformations, and sometimes they can go undiagnosed, but it's not that great of a pressure. And it's also important to note, it's a chronic problem. So this you're looking at something that goes on for many, many years versus something like a brain tumor or a hemorrhage in your brain where it's an acute event. The brain doesn't have time to adapt to that. The fluid, the pressure compartments, they don't have time. So that's where you get into more serious outcomes.
I would add to this, because if you guys go and search on the internet, you're going to see a couple of articles that say Chiari death. And then you say, well, what are these guys talking about? It's very, very rare to have a death from a Chiari. It's been reported. I know Tim George reported a case years ago. The question is that, first, It's very rare. Second, even those patients have been reported, was it truly the Chiari that did this, or did they have an underlying problem? And it's very difficult to dig through case reports. But when you look at the huge registries, the large studies, you don't find those types of data. Yeah.
Hi. For patients who experience Chiari, Syringomyelia, and hydrocephalus as a child, have you ever heard of them experiencing vision, like distorted vision and double vision later as an adult, years post-surgery?
Have you had your shunt revised at some
Multiple
point in your life?
times. I have a subarachnoid and a VP shunt, and they have both been revised within the last 10 years.
Just sometimes, and I think we talked about this yesterday, but people can be very specific in the way they present with the shunt malfunction. So not everybody just deteriorates. Some people will have asymmetry of eye movement and get double vision. Some people will manifest by increasing pressure, and when ophthalmology looks in your eyes, it looks blanched, which is indicative of increased pressure in the absence of headache, vomiting, and all the other things. The good and bad about being in pediatric neurosurgery, if somebody has a shunt and you have what seem to be very random complaints, we're still always fixated on the shunt. And so I would address the shunt. I would always treat that as kind of the first place I would look, which is also the reason why we don't put shunts in, because that's the first place we look.
And then when they're 18, I see them.
Thank you.
I have a real simple question. I am very new to this. This is my first time here. I have a syrinx that goes from C3 to T5 due to trauma. I'm here because I need to find out how is that going to grow? What am I looking for as what will need to be treated in the future? What are limitations? I can read all kinds of things online, and there are differences from people's syrinx being from only 1 inch long and 6 millimeters wide, from like mine is very long and 4 millimeters wide.
I can take a stab at that. What you're asking is a great question, and I think it's something that we don't have a great answer to. I think it's important that you engage with your surgeons or neurologists and whoever's following with you to get very close surveillance. If you were my patient, I probably would do a repeat scan at 3 months and then 6 months. And if that looks stable, then I'd go to a year and then keep following it, because that's really the only way we can kind of turn the page on the book and get natural history. As far as I know, and there's a lot smarter people up here than myself, I don't know of a good way to predict how a syrinx is going to grow over time and generalize that to patients. And if we do come up with that, I think it's going to be really huge. But right now, it's just not out there.
What do you think?
Well, I would totally agree that I would follow with serial MR scans and serial neurological evaluations to see whether there's been any change at all. It may not change, and I would just continue to observe.
Sure. No. Oh, yeah.
Well, one should point out to the insurance company that an MR scan is cheaper than a hospitalization and surgery.
Hi, I apologize if this is basically a repeat of what she just asked you, but I'm curious if there is, consistency on how often we should follow up with MRIs. I try to have my doctor give me one annually, just to make sure everything, I want to follow up with Chiari and Syrinx, Syringomyelia. You know what I was trying to say, Syringomyelia.
Syrinx.
fine, syrinx. And the doctor has said that my syrinx is cleared up, does not want to continue to give me MRIs. I would like to continue to have them, just to make sure nothing comes back and to make sure that the Chiari isn't getting worse, anything like that. So is there an acceptable length? I'd like to do them annually, and he's basically shut me off from that. Is there an acceptable amount of time between MRIs that would be appropriate as the patient to request that?
You can poll everybody. I mean, in my adult population, the only thing I'll follow is the syrinx if there's even a residual. But once the surgery's done, I'll see the patient every year in the office, but I don't get MRIs every year because it really is not going to change anything I'm going to do. Now, if there's symptoms, earlier at the yearly visit, I'm getting some numbness again, I'm getting tingling, some headaches are coming back. That will prompt me to get an MRI.
So if your symptoms never stopped, then he should continue with the MRIs.
Well, if they're new, so it's really more of a stability. If you kind of have plateaued and there's been 2 or 3 MRIs showing stability there, I won't tend to get MRIs unless there's something new or different. And certainly in somebody who's not who is asymptomatic.
Okay. And then my second question is there, perhaps there were a lot of examples of longevity, for example. Is there maybe an example of the longest length of time that you've heard it's taken somebody for improvement? Maybe it's somebody that's had surgery for Chiari and Syringomyelia, and maybe it took them 20 years and then they suddenly had no more symptoms, or any sort of positive story like that? By chance? No.
Oh, yeah. No, I'm sorry. I didn't know that it's 20 years is, in general, patients, depending on the symptoms, and everybody's a little bit different. Headaches, in my experience, are usually the first things that get better. Motor, then sensory symptoms. But, after usually about a year to 2 years, that's what I quote my patients as a plateau point.
So if it's not done by then, probably you're where you're going to be.
Or there's something else going on. Yeah.
Yeah, it's the same as after any kind of trauma, or it depends on the chronicity and I guess how long the symptoms were before. Because there's a lot of neurologic sequela before that was not picked up for several years. That's going to take a long time to improve. And the first goal, of course, is preventing you from getting worse because you've been sliding down. And you first want to then stabilize, make sure you're not continuing to get worse. That you would hope would happen earlier. That within 5 years, I have seen improvement. But yeah, beyond 5, like 10, 20, that's a long time. We're basically managing symptoms and make sure nothing else is coming up. I think what's harder is the patient, when things look so good on the imaging, the patient continues to feel bad and get worse. We don't have an answer for that, but we're always looking for other reasons that we may have missed as to why when that syrinx collapses, some patients don't feel well with that, and it's usually temporary, but some is long-standing, and we're trying to tease out what to do about those patients. There are medications and other things that we talked about earlier today, which could help, but that's a much harder patient population.
Hi, it's Helen again. I missed the lady who asked about the pregnancy, and I just wondered if I could be allowed to say some reassuring things about it. Yes, so 3 things, if I can remember them all. One is a successful Chiari surgeon, the tonsils go up a little bit and the syrinx cavity goes down a little bit. So this implies that there's a problem with this, the problem that threatens the spine in Syringomyelia is low pressure. So when you've alleviated whatever it is that gives you the low pressure, the tonsils go up. So they don't come down, they go up. So that implies that, so when you're pregnant and your average intra-abdominal pressure goes up, this is not really a threat to your spinal cord if you've got syrinx, because it's supporting your tonsils. No, but if you did, imagining that you had the condition, you had low-lying tonsils and you had a syrinx cavity. If you get pregnant and your average intra-abdominal pressure goes up, this is not really a threat to your cord. Okay, there are two main threats. One is raised intracranial pressure. And during pregnancy, the aldosterone system gets downregulated and the pregnancy hormones start to regulate your water balance. A couple of things that happen that are really good. One is your cerebral arteries remodel. So that helps you perfuse your brain. And as well as the arteries remodeling, the sympathetic innervation of your brain increases temporarily, and you get upregulation of aquaporin 4. And all of these things are helping your brain cope with the strain of pregnancy. So your body is working in a very sophisticated way to look after you. So the threat comes from low spinal pressure. So as I think it might have been Dr. Batzdorf said, the problem is if you want an epidural, for goodness sake, make sure it comes with this board guarantee that he's not going to give you a spinal leak, because it is the low pressure that threatens your tonsils and your spine. So the advice that I would give is, why are you having the epidural? Are you having it for comfort? Or are you having it because you're afraid that the woman needs an instrumental delivery? So if you're afraid she's got cephalopelvic disproportion, she hasn't labored before, the baby's big, the baby's 9 pounds, she's got some problems down here, and she might not enjoy pushing, then, why are you doing the epidural? And the best, if you cannot guarantee that this epidural is not going to give you a spinal leak, then really, if the lady's labored before, if you know the size of the baby, if it's all well planned, if she wants a vaginal delivery, then, it's individual, just using a little bit of common sense as to what are the lady's chances of getting that baby out without needing forceps or the nasty snippy business, which is always good to have an epidural, if you're going to be cut. So, if you're going to get cephalopelvic disproportion and panic in the last minute, that would be, that wouldn't be, you understand what I'm saying, don't you? The balance of probability and the balance of risk, and why is this lady asking for an epidural in the first place? So thank you very much.
So I just needed some clarification from a question that I had from yesterday that I heard from Dr. Paolo. So if you've been decompressed and you didn't have a syrinx, your chances are less likely of developing a syrinx. Is that true? Did I hear that correctly?
Unfortunately, not here.
He's not here.
I'm not sure I'm here. Repeat the question.
So if you didn't have a syrinx before decompression and you were decompressed, your chances are less likely that you will never develop one after.
I think that's true.
Yes.
Yeah, not related to the Chiari.
Right.
Right.
So I have some good news for my son.
Yes.
It's good news. It's good news. Okay. Thank you.
My question was back to the ETV surgery. What are some questions that I would want to ask my doctor when discussing, or what anyone would want to ask their doctor when discussing that procedure?
So, the question is there hydrocephalus or not?
Well, I mean, when you're considering the surgery, what are important questions that you would want to ask a doctor to prepare for that?
If you're having ETV surgery? Well, it's a standard procedure. It's the most common endoscopic procedure done in neurosurgery. The complications are well known and they're low. The varying factor with ETV is what is the chance it's going to work. And depending on why you have hydrocephalus, some situations you have a very high chance of it working, and other situations you have a very low chance of it working. So the question, and there is something called ETV success score. And if you calculate this, it will tell you what the chance is that you're going to succeed. It may tell you 50%, 60%, 70%. Does that make sense?
Yes. And then my other question was, how long can you live with hydrocephalus? Is it just a case-by-case basis, depending on how severity?
Yeah.
Yes.
Yeah.
Okay.
Yeah, I mean, you'll see some children that grow into adults that have really, really large heads, and it's just it's a more chronic process. And if it's acute, and the patients have more symptoms, so it really depends.
If you discover you have hydrocephalus, you have to see a neurosurgeon right away. Now, between you and the neurosurgeon, you decide then if you're going to wait, you're going to do something, what you're going to do.
Okay, thank you.
I think this dovetails on some of the other questions that may have been asked, but if you're a patient that's being followed, and let's say you're getting your MRIs every year, and you've been consistently being treated with conservative management, lifestyle changes, all of the things that have been discussed in pharmacy, what are the things that you would be concerned about or patients should be concerned about if they're developing changes, or like, is there any hallmark signals that are like, you should see your specialist earlier than that 1 year mark?
I mean, patients know their own body better than anyone. So you know what your baseline is. And if there's a change that you feel is a change that's different, not 1 day or 2 days, there's always gonna be a little fluctuation, but a consistent change in your symptoms, that's what should prompt you to go to see your doctor. And almost always they're gonna repeat imaging, unless it was just done, within weeks or months.
Yeah, I mean, with the capabilities of telehealth and the MyChart, now where you can just put in questions throughout the year, I think that's been a nice way to have our team help with that and figure out what's something we want to act on versus what probably is not related. But I would encourage you to just, keep in close contact if there are new issues, because you're going to be worried about them because, you're just worried, did it come back? You don't want to have to even think about that. Sometimes a scan is the best way to feel better, just to feel like, okay, it's not, everything's fine. And we sometimes do that where we would have had a scan in 2 years, but we move it up because there's symptoms and, you just want to allay those fears. I think that's fine. We just have to justify it in our notes. Why are we getting the scan for the insurance? But I think you're asking very important questions, and, a year is very arbitrary, right? But you may have to do it sooner. But obviously, if you're closer to the surgery, we're going to be more concerned.
I think to dovetail on that a little bit too, if I have an adult patient who has a Chiari malformation and they don't have a syrinx, but they have some symptoms that could be related, I ask them to keep a pretty detailed diary for a short amount of time, whether that's a month or 2 months or 3 months. And patients will often surprise themselves with the information. And it's not only an exercise for me, and it's an exercise for my patients, because they'll come in and say, hey, I'm having way more headaches than I realized. And that can push us to intervene sooner or follow up sooner and things like that. So that's something that it doesn't need to be initiated by your provider. It's something that you can do yourself too.
Yeah, I mean, I think that during your treatment process, this is a process, a long journey. Like, you might be taking medications or changing medications or working with your neurologist. Like, some of the things, like, I think, oh, wow, they're getting worse, but I'm now taking medications that are helping maybe improve. So, like, how do you determine, like, that's it. I think the journalist.
Yeah, I think your question is a good one, and it's something that I am currently dealing with quite a bit, because I want everybody to get better, right? We all do, and that's why we're here. But it's important to think about changing one thing at a time or one variable at a time. So if something works, you can actually figure it out. And I think that's something that I've learned very early, and I'm still very early in my career. But I think thinking about things systematically and writing things down is the way that I've gotten through that.
A problem that we see more often than we would like is patients and families feeling that they're responsible to make a diagnosis, to figure out when a change happens, what that change is, and when they need surgery, and which symptom is important, which symptom is unimportant. And that's not your responsibility. Your responsibility is to identify changes and relay them to your physician. If you have a good relationship with the physician, he or she will help you figure out whether these symptoms are important, how important they are, what you should do about them. Is there something that can make it better? Oftentimes patients are, maybe they don't want to bother the team as much, or, I just called them last week, and I'm going to call them again. You just have to develop a system with your physician to be able to relay those information. And that alleviates some of the stress that everybody feels, because they say, well, what if something bad happens, and what do I do about it? You just have to have a relationship with your physician.
We have time for just one more, and so Edward's got somebody there.
Hi, this is my first time to be here. I really learned a lot, and I want to thank everybody for help. So my question here now is like, if you have a stack of chairs falling on you on the waist, and then later on you find you have some symptom like numbness in the finger and the arm, and then later on you find that you have Chiari and syrinx. So can you connect those two things? Like if this accident, this cause Chiari and syrinx, or it's just a coincidence?
All right. With Chiari, about 15% of people, and this is Dr. Millerat's data, present after a trauma. And it's not thought that the Chiari came from the trauma. It seems like the trauma exacerbated the problem. And in other words, caused a little bit of scarring or whatever, and caused the Chiari to be symptomatic. On top of that, Chiaris are congenital lesions, but most people present, although the pediatric neurosurgeons are trying to stop that, most people present between 20 and 50. So even though they have the Chiari their whole lives, just these little traumas, a little bit of scarring and this and that sort of tips people over the edge, and it causes something that was just barely wide enough to allow enough spinal fluid to circulate to be too tight and not to circulate well enough. And if it's really bad, then it causes hydrocephalus. If it's bad at the craniocervical junction, it probably causes syringomyelia. If if the tonsils presses on the dura, then you get a bad headache, and worse with coughing and sneezing. Dr. Batzdorf's written about that. So to get back to your question, you're going to fight that with the insurance company. I mean, if you're going to say that, but if you had, for whatever reason, you had an MRI before your accident, then after your accident you had a syrinx, you could say, well, look, I have at least some temporal proof that it caused it, but most people don't have that. And what it's usually known as is that it exacerbated an underlying condition. So it's not like you didn't have a Chiari before the accident, but it just, if you're playing football and you blow out your knee, you probably had a weak knee. It probably wasn't that one hit that did it, but it depends on how you look at it.
Okay, so the hit is on the waist. It's not in the head or neck.
Where's your syrinx?
What?
Oh, I'm sorry.
Syrinx. Yeah, the chair just fall on the waist, not on the head.
Oh, on your waist, so you don't have a
Not
Chiari.
on the head or not on the neck. It's just very low. So that still can be the
trauma can cause. Yeah, it just depends if you could make the case that it caused enough trauma to cause some scarring or bleeding or whatever. So it would have to be plausible, and That's why, a physician would have to, plaintiff's physician would testify one way and the insurance company physician would testify that nothing happened and then they'd fight it out and they'd sit on their Jaguars and they'd settle the suit. That's how it usually goes,
So is that the same situation with the syringe? So you may like, I already have syringe, but I have those symptoms and this accident caused the symptom to appear. Is that what?
Well, that you could make the case that it exacerbated an underlying condition. That's how it's described in medicine. It exacerbated means made worse an underlying condition. In other words, you can have a little trauma can bring out something that you didn't know.
Okay, so you have no way to tell which is the cause, right? This trauma caused this.
There's no way I could take more classes or get more degrees, take more fellowships to figure that one out.
Okay, yeah, because we don't have tests before, so.
Maybe an AI. We'll use AI.
Okay.
Okay. Well, thank you. Thank you, panel. Thank you, everybody.